as statewide policy development. With that, I know we have a lot we want to cover today, and Monica's going to go over some housekeeping for us so that we can hop right on into our presentations. And just a little bit of background, we at CCJBH have celebrated, this is our second year celebrating May as Mental Health Awareness Month. And one of the activities that we do are these Lunch and Learn webinars. We've typically done them once a week. And for this month, we kicked it off with Cal Hope with the Department of Healthcare Services. And last week, we had a presentation from the Board of State and Community Corrections adult reentry grants to really talk about housing, the work they're doing in the housing space and rental assistance. This week we have our lived experience perspective, so valuable for the work that we do and absolutely critical to the work we do. And next week we will have the California Department of Public Health talking about their California mental health, community mental health equity project. And we're also, of course, always putting out our Friday blast with information about the May is Mental Health Awareness activities. So without further ado, I will turn it over to Monica to do some housekeeping, and we will hop right into our presentations. Thank you, everybody.
Great, thanks, Brenda. Good afternoon, everybody. Just some quick housekeeping for everybody. The webinar is being recorded, so it will be available once it's remediated. It'll go on our website, so please come out and check it out and share it. We will have a session, or towards the end of the presentation, we'll take questions or comments for our presenters. If at any time you want to ask a question, we ask that you raise your hand, and then there's actually a raise your hand feature on your screen. You'll be placed in the order that you raise your hand. Zoom kind of helps us out with that. And we ask that you keep your comments to at least 3 minutes. Sometimes we run a little short, and we know that a lot of people tend to, they want to get their comments in. But if for some reason you don't want to do it live, or you don't get a chance to, we encourage you to send it to our email address at ccjbh@cdcr.ca.gov, and we're happy to route it to our LARRP presenters, or we can help redirect the question as appropriate. Oh, let me see. I'm sorry, that was out of order. We have a webinar policy for participation. We welcome your participation throughout the meeting. We ask that we don't condone or support any disruptive behavior. If you are disruptive, we will remove you from the session without warning. If for some reason our meeting is compromised, we will end the meeting immediately and then send out a session. Comments, we ask that you keep them appropriate to the presentation. And we also want to let everybody know that any Q&A conversation or chat conversation that happens is not necessarily reflective of CCJBH, the Department of Corrections and Rehabilitation, or the California Correctional Health Care Services Division. So without further ado, I would like to welcome and also introduce Jane Bond, which is a LARRP leader for LARRP. And I would like to turn it over to Anthony Garcia, who's a program director over at LARRP. So thank you and welcome.
Thank you for having me.
Oh, it looks like you're on mute, Anthony.
Sounds like he's making good.
In terms of his lip reading, it sounds like he says he's having technical difficulties.
Oh.
So I can try to share screen or
Okay.
send that over. But in the beginning of the presentation, it is introductions of presenters. So Jane, if you don't mind, if you could just introduce yourself yourself while we get this going.
Hi, sure, of course. Thank you. I'm Jane Bond. I'm a LARP leader, cohort number 2. I do a variety of different things in the community, but the cohort number 2 is really push my advocate heart like really, really big. So really,
My apologies. Sorry about that. I just had to shut off my screen and turn it back on. I'm going to share my screen now so I can get started with the presentation. I don't know why my screen just went black on me a few minutes ago.
I could see it, Anthony.
We can see it, yeah.
Yeah, okay.
At least part of it. I was gonna say, we have the presentation. Can we pull it up for Anthony?
Yeah, it's just my screen keeps going black on my end. I don't know what's going on with that. My apologies.
Let me, if you or if I have it right here, Monica, if you want to share screen.
Yeah, I can pull. Yeah,
Okay.
let me, I have it open as well. Let me go ahead and share it.
I'm not sure if you have the most updated version though.
Oh, okay.
This is for the open discussion. We did add questions there. So
Oh,
apologies.
okay.
for that.
You want to send it over? I will go ahead and,
Perfect, yeah. Just send it in a PDF. Okay, I just sent it. Oh, now we can, oh. Anthony, are you there?
Yeah, I am here actually. Can you see my screen?
Yeah, it's in now.
Okay, perfect.
Whatever you
Is
did.
it whatever I did is working, right? Okay.
Yep.
My
Yep.
apologies to
And we can
everybody.
hear you.
Okay, perfect.
So take it
I don't-
away, Anthony. Thank
Having a
you.
glitch. Sorry about that. So hi, my name is Anthony Garcia. I'm with the Los Angeles Regional Reentry Partnership, and I am here to speak about wellness within our leaders. So who we are, like I said, I'm Anthony Garcia, the program coordinator. I oversee the Leadership Training Academy, which is the lived experience regional project presented to you by CCJBH, and I am accompanied by the one and only
Jane Bond.
who is a LARP leader and is actually part of the training academy. So I'm going to just quickly go over what LARP's mission is. LARP's mission consists of 3 sections, which is to host a dedicated space for reentry professionals and impacted people to convene regularly, share information, resources, and referrals to better serve people in reentry. Our second mission is to prioritize and advance promising and evidence-based practices for reentry service delivery. And our third will be to identify and advocate for administrative, legislative, and funding policy reform related to issue committees, area of focus. As if you don't know, LARP is divided into subcommittees, issue committees that provide a focus to integrated health, employment, and education. Housing as well, and faith-based, but for the sake of the Leadership Training Academy, we tend to focus on those 3 areas, which is education, integrated health, and employment. The service providing that LARP does breaks down in 4 facets, which is the systems, convening, policy, and capacity. On a systems level, we help to build systems that involve planning, delivering, and evaluating an effective community reintegration process within the Los Angeles County. The convenings that we have is to serve as a conduit and to gather local feedback of regional and statewide policy development. The policy we do is to develop and implement legislative and administrative policies that reduce recidivism, improve public safety, and decrease incarceration levels while providing accountability to taxpayers, protecting against costly liabilities and reducing structural inequalities. Then the capacity building that we do it to provide capacity building opportunities for the providers of those services, both public and private agencies. And just a fun fact about LARP, So LARP, as you can see in the bottom right corner, that's our executive director, Troy Vaughn, with our leading policy queen, Lynn Lyman, who has been part of multiple fronts and legislative efforts that have helped reshape and reform LA County and the statewide policies that currently needed to be reformed, just to say the least. So what we do here at LARRP is we promote an overall wellness mindset, culture, and environment. We do it by starting out with cognitive functioning, which is the study of, or the behavior of the thoughts, feelings, and behaviors, That consists of a focus of thoughts, behaviors, and feelings. And we believe that that's a very important part to start from, because that overall encompasses everything else. That overlaps with your health, with your self-awareness, with your well-being, with your attention, cognitive flexibility, which is adaptability, and emotional regulation, or emotional intelligence, as others call it. We actually practice this in a hierarchy level. We actually function as LARRP and staff. We promote this wellness mindset. So then it trickles out to the agency. And then it trickles out to the staff themselves. And then we express that, we push that energy out and that mindset to the leaders themselves. Overall, we can say that this creates an environment, this creates a wellness culture, and overall the work that we're actually putting out is effective to make an impact of wellness in our community. So the practices that we actually apply on a day-to-day or week-to-week, so I can say, is we actually make an effort to use these out of the norm meditative practices or spiritual or mindful practices, so I can say. We tend to use our wellness committee to apply meditation once a week amongst the staff. We actually do group physical activities as well. We've gone beach bike cycling. We've done Zoom team exercising as well. We've also done mindful relaxation, where we actually have mindfulness activities where we actually engage with each other in stress-free activities, playing games like Jeopardy and other games that are very fun and creative that create team building. And then we also have a creating space in our office where we can have open discussions and we can have those healthy conversations that I believe need to happen in workplace environments. Now, I'm going to touch a little bit on the Leadership Training Academy, what it is and how it's been up until this point. So the Leadership Training Academy consists of a diverse group of 12 individuals who are formerly incarcerated in the reentry system, everything ranging from long-term incarceration to short-term incarceration. And one thing we all have in common, of course, is that we're all in the reentry space. Some of them may have to battle with behavioral health issues that are on the higher spectrum than on the lower spectrum or less end spectrum. And we purposely diversified this group of individuals because we believe that each one offered leadership quality and skills that can be elevated, that can be enhanced to therefore become better leaders in our community. So we actually launched last year, which is cohort 1, which is the top section of it. And right now we're actually ending cohort 2, which is the bottom section. And actually, which Jane Bond is a part of as well. So the training academy, the Leadership Training Academy, consists of various components that we actually applied in the modeling to benefit the leaders and how they're going to go through this program. Everything consisted of training to bringing family in and being part of this experience throughout the Leadership Training Academy, to community-based research that we've done and we're doing, to being a part of policy reform. that impacted those who haven't had a seat at the table in the past, or who have been voiceless, or who haven't been heard, to actually doing social media campaigns and bringing more awareness to mental health stigma and these policy reforms that we actually advocating for. And one of the most important pieces to all of this is, I believe, is a reflection and journaling piece, right? Throughout all that work we've done, take the time to reflect and actually journal out what you did, or even record yourself to journal it in a video format. So here's a section where we actually put together to have an open discussion, me and Jane, where we will be answering these questions, right? Myself being in reentry space as well, being formerly incarcerated, having served over a decade in prison, not having had the privilege to come home and work as a service provider. After leaving finance, I pivoted careers and I went into social services to give back to my community and help. Therefore, I find myself here today as a service provider, but also as a peer. And Jane, on the other hand, has also been a service provider in the past and also serves as a peer. So here we're going to do our best to answer these questions and engage in open discussion amongst me and her. So I'd like to pose a question, Jane.
Yes.
What are some of the mental health needs of individuals who are just as involved and have behavioral health conditions that you encountered when providing services as a service provider in the past?
Thank you, Anthony. As a service provider, what I've encountered is their barriers is trust. They have no trust in the service provider. They might be there because they have to be, parole or probation, but anything that they might feel like they need help on, they'll refrain from telling you right away because they're afraid it's going to go down in their permanent record, or that they are going to be diagnosed and given medication before they're allowed to say it is why they're there, what they need help with. And so I think that culturally, having to speak in general to any provider, it could be seen as a failure of the family. And also, sometimes we have to, when you were speaking about not having that voice, we muffle our voices just to keep the family intact. Because many times, we've reached out, or they have reached out, and they're like, their kids get taken away, and so they're just really leery. I think it's a lot of trust. It's not necessarily that they need medication, and they just need to talk. They need to be asked a follow-up question, and there's a lot of distrust in the provider. That's what I have found, actually.
Thank you very much for that, Jane. Just to answer that question and give my perspective on what I've experienced, coming home, I recall that I didn't have healthcare coverage. I didn't have mental health services. So it became kind of difficult for me to pick up the phone and call a mental health provider and ask, hey, can you help me? Because the first thing they would ask, well, are you insured, right? Do you have health coverage? And if you don't, well, there you are faced with a barrier within itself. And I eventually, joined a firm who gave me healthcare coverage, who then provided me with the mental health needs that I needed. But that's not the outcome for everybody. For most people, that's not the outcome. The majority of people are actually by default subjected to go and apply for state help or county help. And they don't even know how to navigate getting to the office to even apply. So, one of the biggest barriers that I see there with that is not having come home already with healthcare coverage. That I think that is something that could be remedied, that we can collaborate with multiple agencies to make that happen, just like the license and the Social Security effort was just done recently. And I believe that healthcare coverage for those before they come home, so that way they already have it in their plan, like a pre-release plan, would be vital to tackling this mental health service providing piece. And as a service provider, one of the barriers that I actually encountered with helping those that are in need out when providing services is that the system is very complex to navigate through. If you know, as it is, mental health services is a very complex issue, but to know somebody suffering with DID, you know, there wasn't somebody to help with that condition, specific condition. Or, you know, bipolar, I would have to, you know, I would have to reach out to my resources because I know who they are, but those that are coming home wouldn't know who to turn to. In my case, even me knowing a vast network of mental health service providers, I still had a challenge to provide adequate mental health services to those that needed it. Because one agency couldn't do it because they don't specialize in that type of mental health care. So they referred me to somebody else who then referred me to somebody else. And it became this baton handoff, so to say. That's the way it felt. So that's the way the current system operates on. And it's not easy, but I believe more can be done and more should be done. So I'm going to move on to the next question, Jane. What are some barriers that the behavioral health or justice involved population face when trying to access mental health services?
Well, being part of that system, you know, and you spoke about DID. My diagnosis is dissociative identity disorder. So some of the barriers, and I just was recently diagnosed over the last a year ago. And but for the longest time, I was diagnosed bipolar, right? So I knew that there was, I had my first suicide attempt when I was 16. And then, you know, I was also gay at the time when it was not normal. I mean, you know, when it was really frowned upon. So, you know, one of my barriers is when I felt like I wanted to get help, I went to the mental health services, and you know, the first was the courage to get past the cultural stigma. You know, my family is like, I didn't raise you like that, or you know, or just take a drink, a stiff drink will work, you know, and it did for them, but me, it did not work that way. So, you know, I'm in front of a social worker and they don't look up, you know, and I'm telling them these feelings that I'm having, or these, I guess they're symptoms. At that point, I didn't realize they were symptoms. And next, I was bipolar, and that was it. And that stuck with me for my whole, up until last year. So, you know, the lack of empathetic social service workers, where it's like a drive-through mental health, you know, where you're not looking up, you're not really hearing the client. And, you know, that the lack of therapists or if that are of color, that's a big one. If I'm sitting across from somebody and I'm like, well, how can they know my struggle? And I know that's different because I've been on the other side of it for 12 years. But before that, I was like, you don't know my struggle. And I think that would definitely be, that's a barrier, you know, because it's easy for somebody to say, well, why don't you just talk about it? But culturally, it's not stuff we're supposed to talk about, you know. Transportation, as you were saying, you know, lack of case management, you know, not properly educating a person when they come in to go seek services. What is going to be, what's HIPAA protected and what's not? That would be part of it. I think those are the barriers. And of course, we're going to go back down to trust. You know, when I finally got my diagnosis of DID, it was hard. It's hard. It's very hard still to find services that will benefit me. But, you know, I had private insurance for a long time. So that's how I was able to get diagnosed. But it was like, oh, it was such a moment of like, oh, that makes sense. You know, why medications don't work for me. And I think it's that cookie cutter approach. I think definitely that's a barrier. And I think that those things being addressed would help tremendously.
Yeah, so what I'm hearing from you is that not one size fits all in terms of diagnoses and mental health disorders or illnesses you may be dealing with. But thank you very much for your answer on that, Jane. I forgot to mention this in the beginning before I started the questions. If any of the other panelists like to step in and you know ask further on the answers, or actually elaborate a little bit on would like us to elaborate a little bit on our answers as well, you're more than welcome to join in. But there is going to be a next section for Q&A just to give the audience and the other panelists that opportunity to speak as well. Okay. But I will say this, in terms of question 2, for myself, you know, like I mentioned in question 1, briefly about the barriers that we're confronted with in providing mental health services to people that I've served in the past, and even to this day. Jane actually briefly touched on it, how the approach that I'm taking, it's more like a one-size-fits-all type of approach, where by default they do a quick assessment, they evaluate you, and if you fall in a category that needs prescribed medication, they do not hesitate to give it to you, despite whatever, you know, the case may be. In some cases, you know, I've seen it myself, where mental health prescription medication is actually prescribed for as or in replacement of pain meds, which is another you know, a barrier within itself in terms of how they're distributing that medication goes. You know, somebody dealing with both of those issues, pain and mental health, you know, I've seen that scenarios where with somebody breaks their leg, or, you know, hurt themselves, and then they're dealing with mental health issues already. And, you know, in order for them to be provided adequate healthcare services and mental health care services, you know, they're provided with this concoction of medications that then, you know, unfortunately led to much more complications in that individual's health. So, you know, that these are cases that I've had to experience, you know, being a service care provider in the space, and having been in reentry and seeing that done to my community, to my members, and my community really hurts, because there isn't an easy solution to this problem. But I believe measures can be taken that are better in terms of, you know, case planning and adequate case management, specifically focused in mental health, upon reentering back out to the community. I believe that everybody has, to an extent, a mental health issue upon transitioning from incarceration, because nobody spending long-term incarceration in the incarceral system can say that they're fully sane or there's nothing wrong with them, because that's not normal by any means. Yeah. But that's just my answer for number 2.
As I say, before Jane comes in, since you invited us to ask questions as other panelists, Anthony, and this actually would be for you and Jane. You know, with DHCS's CalAIM initiative, they're going to be launching right now. Some of the counties and the rest of them, as of July 1, will be launching enhanced care management, the new enhanced care management benefit, which is like care coordination across all the Medi-Cal delivery systems. So primary care, mental health, substance use care, they'll be coordinating all that, as well as addressing social determinants of health. What do you think the peer role could be or should be in working with those enhanced care managers, or serving as enhanced care managers?
I honestly believe that a training in place should be implemented for peers to actually be direct service providers, because the lived experience population trust more of their peers than they do strangers, right? If you cannot relate to somebody who has not been in the carceral system, they simply will not trust you, because you don't know the experience they've been through. You cannot relate to the traumas they've been through. And unfortunately, a lot of the common childhood traumas are actually the same that they've gone through, and results in the actions and behaviors, antisocial actions and behaviors that resulted in the individual's crimes. So if you want to really get to somebody deep, mental health challenges or not, I believe that the peers should be in the forefront, boots on the ground, active, community resource members who are providing that service, in my opinion.
You know, Brenda, I want to follow up on that. So currently I am finishing up and starting an internship for it is a mental health peer specialist training. I wanted to add that onto my repertoire, because I think it's super important that us as peers, reach out to other peers, because like Anthony is saying, like, we don't have to for instance, my diagnosis, DID, is an event-activated trauma. If you're 6 and under and there's severe sexual trauma, physical or emotional or psychological damage to a child 6 and under, they have their chance of getting DID is increased exponentially, like 100%. And so when I, as a peer, I'm talking to some of my peers, and I'm like, they say I've had severe sexual trauma at age 6, so have they. And there's this like quiet knowing that we know that we share in some commonality, and that we probably have some event activated trauma that if we didn't have, we would not have that diagnosis. And I think that just knowing that quietness of this, like knowing that we understand each other without saying anything, says a lot. You know, when we're talking to a therapist or a person who is educated in this, we have to kind of go over it too much. I know that talking about my trauma at times can be overwhelming, and it's just nice when you don't have to, simply because, and it's unfortunate that it occurs that way, that there's so much trauma that all of us have experienced, you know, that's created our mental health issues, or have definitely had a hand in it, that we can say things without having to say things. And I think that's super important. So I took my training at DCRC, the Disability Community Resource Center. So anybody who's interested in that would definitely be able to reach out to them. And it's free if you have mental health services, which is like a big deal, because the class normally is like $5,000. And I graduated the class of 6, and one of them was non-sighted, and my teacher's non-sighted. So it gave me a lot of introspective into like what I'm grateful for, you know, and that I didn't even know a program like this existed. And I was like amazed, you know, and we have a lot of peers here who are just willing to go. I just want to go there and help their peers. That is a big deal, you know, that's a huge deal. And it
Thank you very much for that.
Yeah, good. I'm sorry.
Thank you very much for that, Jane.
Yeah, thank you both for answering that question. I think that's very insightful, and appreciate you sharing your story, Jane.
And I'd just like to elaborate a little bit on that answer, Brenda, real quick before I continue. Another component that I missed out is paying the peers an adequate wage to be able to be self-sustainable, self-reliant, right? Where they don't have to get 2 or 3 jobs if that's the plan that's going to be implemented in hiring peers. So yeah, I'm gonna continue on with the next question, and then we're gonna move forward with that. So what can be done to increase the chances that the behavioral health justice involved population will utilize public mental health services? I mean, to answer that question, I'm gonna let Jane go first, since I went first last time.
When I read this, I said, you know, I was passing by a billboard in a, you know, marginalized community. It was beer, you know, shit, I think it was some kind of alcohol. And I said, you know, that's what's needed. What could be done to increase the chances that the population will advertise them? You know, instead of putting that alcohol or that cigarette billboard up in the community where there's going to be one every 5 feet, maybe put the services that can be offered to them, more case management. That's definitely it. I was speaking with my class before I came on, and I said, you know, and we also have the same, more case management services. You know, instead of advertising the alcohol and beer and advertise what's available to them. Because I know a lot of people come, when I was service providing, or I still do, they didn't know that services were available to them. They didn't know about they also didn't know about some of the things that, like when the LAPD had lost their, had to go out and provide services for gang members because, you know, the judge, you know, determined that it was not a gang, just kicking it together. People didn't even know they had access to those services. And by the time they found out, it was already over. And those are the things that would build trust, would give information, you know, developing an assessment, mental health assessment that's HIPAA protected, that assures them that the initial assessment is just an assessment to gauge their need, not a diagnosis, not medication. It's not a bait and switch. We're not here to take your children. You know, I might have not went for help from the beginning if I would have had a child, because I've too many horror stories on that. So I think that, developing, and what I've been working on is self-like, I guess, but a compulsory assessment for therapeutic services that asks generalized questions, but together they can form a good picture of trauma that may have been introduced in that person's life. That doesn't mean they need medication or they need full psych. They just might need somebody to talk to, somebody ask them a follow-up question. I think that just definitely more case management services, as you were saying, more information. A lot of my peers and a lot of my clients, we don't receive the information adequately to make the choice. We just, they just depend on that, what's best for me, but they don't trust you. So it's kind of like, it's like a little teeter-totter there.
Yeah, thank you very much for that, Jane. Now, for my answer, Jane mentioned made a few points that were actually points that I was going to make.
I'm sorry.
It comes to trust. It comes to trust. Sorry, can you hear me? Yeah, I don't know why my camera is black, right?
Probably because you're sharing your screen, I'm assuming. That's what I was guessing.
Okay. I don't know why what's going on with my screen, but
No
if you can hear me, I'll continue.
We can hear you. Yep.
Okay. So my answer to that question is, it goes back to utilizing a trust system, right? A trust system built on peers that actually know what they're doing, serve as of a mentorship approach, I want to say, and I want to make the point of why that would be important as an overlap, because as it is, the lived experience population comes from communities of color, for the majority of them, that heavily stigmatize mental health or any behavioral health issues, right, within our communities. So for anybody to realistically say and feel confident and say that they're going to admit to their family members or their community as a whole that they suffer from any mental health or behavioral health issues is probably, I can safely say it's not realistic, because we're not there as a community yet. But what has worked, and what has worked for me, and what I see working in the space currently right now, is people who come home and want to seek services to change their life and actually active in the community and are participating in community events and are putting in the effort. They work well with an assigned mentor that can work that's a peer. But it would be even better if they had a component of behavioral health expertise behind them, so they can know how to navigate when they're confronted with that reality that somebody has disclosed to the peer that they suffer from mental health issues. So that way they will know what to do, right? If we have a trained peer who already knows what to do in that scenario, they'll know where to guide that individual who's suffering from mental health or behavioral health issues. So, yeah.
Go ahead, Anthony. I'll follow up after.
Okay. And that's just my opinion in terms of what would be good methods to increase the chances of people utilizing such said system. It would be to actively have a peer that's trained and know what to do and know how to navigate in that public mental health system itself.
So I wanted to follow up. So there's a lot. So, children go to, when children go to school, let's say they're coming through, they live in the projects. They hear gunshots all night. Their mother's in prison. Their dad's in rehab. Their uncle, and they live with their uncle and their grandmother, and uncle's molesting them. They go to school, they have to walk through, metal detectors. This is in, of course, socioeconomic disadvantaged communities of color. And they by the time they get to school, they're just not, they have PTSD. I mean, by the whole event, everything they're going through, and they're in depression, they're traumatized, and they're in school and they're not paying attention. Let's say that they got hit when they were children, their mom was abusive or dad was abusive, and they don't have hearing. So they're sitting there and people are thinking that they're slow, or some teachers or some healthcare, they're slow, they're bad children, they're already, they make all the assumptions. But really, this person has PTSD. Really, this child's living in trauma. These are the things that are like, they're afraid to speak, because if they speak, then they're going to be railroaded into the, and this is not something, this is something that I hear a lot. They'll be railroaded into the system. They're going to be taken away from their family if they speak about it. They can't say they can't hear, because that means that somebody hit them because, you know, there was some issue, and that's would be the truth. So they're just sitting in class and they're trying to learn, but they just don't know how to learn because they've got all these other things in their brain, and they're trying to somebody to ask them a follow-up question, you know, and they don't get it. And I think that's what I'm talking about when I talk about more information, more case management services, knowing the difference between how this person's, what this child's family life was like, or when they're coming home from, you know, the system. That right there, straight off the gate, probably needed to be when they're coming out of prison. You need to be seen. You need to go see a therapist and see how your PTSD is going to affect your life. That's not necessarily medication for a long time, or even medication at all. It's therapy. And I think that definitely more just asking follow-up questions, I think in the trust and in the case management service, I think would provide a big leap into helping normalize therapy and mental health care for yourself. Self-care.
Thank you very much for that answer, Jane. Would any of the other panelists like to ask questions in terms of what we've asked so far or answered on the question so far? If not, we can move to the last question.
So go ahead and go for the last question, then we'll open it up for
Okay.
questions from our participants too, because it looks like we've already got one in the Q&A.
Okay, thank you. So I'm going to move on to question 4. Working with vulnerable populations such as behavioral health, justice evolved populations can sometimes be challenging. As a service provider and or peer, what are some ways that you can take care of your mental health? So, you know, I'm going to answer this one, and I'm going to lean off of a LARRP's model of wellness, of continuously, you know, creating a model and putting out that mental health model of wellness for our staff, for our agency, and for our leaders. We all, you know, we tend to practice it on a day-to-day, on a week-to-week. We actually created a wellness committee at our agency revolving around this that actually checks in on each and one of the agency employees that I work alongside with. My amazing team and I always check on each other in terms of how we're doing, right? How was our day? How was our weekend? And, you know, just as somebody who genuinely cares, not seeing me as a CDC number, not seeing me as somebody who's in reentry, not seeing me as somebody who has any mental health issues, but as a human being, as somebody who cares. So if you come from that perspective with that intention, with that compassion, I believe that the people you are serving and yourself, you will have that grounding moment, I guess, to say, to make sure you take care of yourself, because somebody's showing you that they care about you. So I think that's very important in terms of creating a culture and environment that is led by wellness. Like I said, we use methods such as meditation practices, team building practices amongst the peers, amongst peers and coworkers, to also doing exercising, you know, practices together, where we go to the beach and we cycle as a team together to make sure that, you know, we create that balance of wellness within our culture and environment. But that's my answer. Jane, would you like to?
Sure. I ground myself using aromatherapy. So with I carry something like this with me at all times. Well, I do meditate every morning and every night. Let love in and let negativity out during the evening time. And so during the other day, I use aromatherapy. For me, I figured that out, or it was given me as a tool with the dissociative identity disorder diagnosis, DID. The only thing that can work for my diagnosis is therapy. I can't be prescribed therapy. That's what helps me in aromatherapy. It just grounds me. So throughout my day, if I'm talking with somebody, or I'm more of an empath than I thought I was. Recently, I learned that. So I take on a lot, and I haven't really figured out how to let that pass through or block it yet. But when I do my aroma, it just grounds me back to the moment. And that's been very, very helpful for me. I highly recommend it.
Thank you, Jane. So now that concludes our questions, and I'm gonna turn it over to Brenda.
Thank you. Thank you so much, Anthony and Jane. I think that was just, it was really helpful for you to walk us through the questions. I think you had some great ideas or things that you shared in terms of what some of the barriers are, what some of the challenges are, some of the areas that the systems need to be strengthened. The good thing, as you were talking, it made me think of all of the efforts that are currently underway to address some of these issues that you've brought up. I popped into the chat I call it kind of a cheat sheet that we at CCJBH made for the California Advancing and Innovating Medi-Cal or CalAIM initiative that DHCS has launched. And we had taken the proposal and pulled out all the efforts that are going specifically targeted or going to benefit the justice involved population. So Anthony, things like you were saying about getting people enrolled on a Medi-Cal before they're released, the DHCS is working on that with pre-release Medi-Cal application, like helping fill out applications and getting people enrolled. CDCR has been doing that, but it hasn't been happening in a standardized manner across the state in jails. So they're very actively working on that right now. And then what DHCS, Department of Healthcare Services, is also working on is they're negotiating right now with the federal government for what's called 90-day in-reach services, so that these enhanced care management providers can actually go and do in-reach services into jails and prisons to do that pre-release planning, that case management that you're talking about, and care coordination for them. So things are in the works, and so it'd be great if you guys are tracking those efforts as well, because I think your question or your responses to the question that I asked in terms of what's needed to make that successful, you're saying that having peers really be part of that that process is key for trust and helping support people and have them feel confident in and willing to receive those services. So so I think you guys brought up some great things in regards to the systems, but also in terms of just your experiences. Thank you for being so candid with how you've experienced throughout your life, your childhood and on into adulthood and transitioning, and all the great work. I'm always so impressed by you both of you, when you get out there and you're presenting and sharing this information. It's your expertise is just so valuable, and I know I've taken it personally. Even in the work that I do, I've learned so much from just hearing you guys talk in different venues and being able to apply that to my thinking and my work in this space. So thank you for being willing to do that, so that people like me can learn and have that and inform the work that we do and the products that we make. So with that, I know we've got some questions. It looks like James Mackey, hopefully I've said your name correctly. What kind of, and this I think goes back to Jane, when you were talking about the certification that you're working on and the services that you guys are talking about in terms of peer services. He was asking what kind of services you're talking about, because becoming licensed by the Board of Behavioral Services, if you're formerly incarcerated, is problematic because that the record issue. And so, what's the scope of practice for those who are peer certified? So, like, what is? Can you say a little bit more about the peer specialist classification and the certification? That would be
the mental health peer certification. Yes, it is. I would hope that at this, with Prop 47 and all the record-changing events that have gone on for many years. I know that Lynn Lyman was like instrumental in the Prop 47. It is beneficial to get your record cleared before you do any of the. Because you have 7 weeks. So it depends what's on your record. It's not like no. It's not absolutely no, because they can ask for exceptions. But right here we're doing the peer, the mental health peer certification. And is as a peer, they're allowing, it's not as stringent as, like, for instance, the AB 109. When I was being processed through for AB 109, which actually had me start doing the Prop 47 stuff, where they were clearing us like if they were clearing a probation officer. And so throughout time, they've been able to, you're not a probation officer, so there's a lot of different things that there's things that I didn't need to be cleared for that I actually was at that time. So I know things have changed a lot. So we're learning case management skills. So you're learning intake, you're learning about the rules and regulations, the titles that ADA titles, you're learning about, we're doing a lot of role playing, you're learning about intake, discharge, you're learning basic case management skills. You're not a counselor, they're not, although I do have the counselor credential, they're not trained to be counselors. What they're trained to do is to sit down with you initially, and as a peer, try to assess what some of your needs are, and then after we do the certification, you do a 91 hours of internship. So you're getting more on the job training. I know that some of my peers here did have a record, so I geared them towards record clearing events throughout the community. And I would highly recommend that, but it's not a no. It used to be no right off the bat. I can personally say that it's not like that anymore.
And thank you, Jane and Anna, for elaborating. I was trying to put into the chat. Sorry. Oh, can you hear me?
Yeah, and then also I just received something in the mail regarding that they're accepting RFPs for different peer certifications, not just mental health, but parenting, caregiving, different things. So I encourage DCRC to let me do that for them. No, but I am trying to get them to go that direction with more services like that.
Great. Yeah, and you make a good point too, that there's peers in the behavioral health space. So I know DHC, Department of Healthcare Services, is doing a lot of work with the peer certification. So I popped that into the chat for anyone who might be interested in that. But peers can work across delivery systems. So you could have peers working in criminal justice, like in probation and parole, or in jails, prisons. That happens not as often, maybe in California. It's in spots around California. We've been looking to other states to see what they're doing, because some states are doing that a lot more in their systems. And then, housing, I've heard, even peers being used within housing continuums of care. So there's different sectors that, are, I think, the behavioral health justice involved population rely on for services, where peers are very helpful and instrumental in getting folks connected up. And I think, Jane, are you working on the behavioral health peer cert, or like the mental health peer certification? Yes. Is that the specific one you're talking about? Yep. Yes. And which is really important and building out. And I know the Department of Healthcare Services also, as part of this work, is looking to develop a distinct service, like distinct provider type and a distinct peer service type in the state plan, so that those would be billable to Medi-Cal. So a lot of that work's being done as well. And so we're trying to stay on top of that ourselves. It looks like we have a few more questions. Looks like Steve asked, are other counties aware of the plans to shape their re-entry plans, particularly neighboring counties? Like to LA, like Orange, Riverside, and San Bernardino. Be safe, be well. And Steve, I'm not sure. I don't know if maybe you can come off mute, or if you're willing to come off mute. What you're thinking? Are you talking about Cal-AIM, or something that Jane and Anthony were talking about? Are we able to unmute Steve from my team?
Yes, okay. Steve can, if
oh
you
yeah,
would like to.
I was just wondering, can you hear me okay?
Yeah, hey Steve.
Yeah.
Hi. Yeah, I really like your presentation. And what I was wondering is, are the other counties around you aware of LARRP and what you're doing to shape the thinking of their reentry plans? I didn't word it very well, but that's what I was trying to say.
Thank you very much for that, Steve. And yeah, so we're a regional community-based organization. So where our reach goes from one end to the county to the other, and therefore we collaborate as much as we can, and we actually make the effort to collaborate with other counties. So we actually partnered up with San Diego's Roundtable. That's our point of contact down in San Diego. So we are expanding we're expanding pretty fast, but we are actually continuously nurturing and building relationships with other counties as well, and CBOs who are active in the space, who are just like us, if not a service provider, that are directly providing services for the reentry population. But we are actually making an effort to build and expand out our relationships with other counties. The thought process is to have other organizations that are in the space become just collaborative partners versus LARRP expanding out to their county. If the opportunity presents itself, I'm sure that the team will consider that. But for now, what we're trying to do is just expand our network to the most that we can to make sure that we change the system from the people within the system that currently is in. If that answers your question.
Well, thank you. But specifically, has any of those LA, has Orange County, Riverside, or San Bernardino been involved with what you're doing, or do you know?
Yeah, that I know of right now, we have the furthest out that I believe we have is Antelope Valley, who has a partnership with San Bernardino, if I'm not mistaken, with agencies. I just cannot think of their names right now on the top of my head.
Okay,
my apologies
no
about that. But
Yep.
Out that way, we do have a connection. In Orange County, I'm not too sure. We have a former leader who actually is active in the space, who just got hired into a community-based organization. So I'm actually in the works of trying to set up a healthy relationship with agencies down there in Orange County. So we're actively doing this right now as we speak.
Okay, I'd like to see if I might facilitate some of that, just because I'm sort of focused on those 4 counties are 1 TV market, 1 radio market, 45% of California, and America's 5th largest state. So I'll tell you what, I'll put my contact information. Maybe if you give me a holler, I can see what I can do.
Will do. Thank you very much for that.
Thanks.
Thanks, Steve. And I know we've got we're right at the time, but I was also going to say the question on, are there MHSA restrictions on funding peers outside of healthcare agencies? So, I think that would, I guess I would need to think about more of it, just because, a few questions come to my mind when I hear that question or see that question. But typically MHSA dollars are going to county behavioral health, and they can use those funds to fund peers, to use those monies to fund peers, and those peers can work throughout the community. So I think it would be to the extent that the counties enter into relationships with other entities for those services, but typically they're anchored to behavioral health services because they are MHSA funds. But I think that would have to be further explored depending on whatever the project would be. Sorry, I know that's not a really good, clear answer, Steve, but it's probably a more complicated question than a fast answer. And then the last one from Luis, I think you were talking about the mild to moderate, the need for qualified professionals to help with mental health services, the hope for Medi-Cal managed care plans to be the link for justice involved mild to moderate mental health diagnoses so that they may receive services as well. And can't agree more with you on that one. Just so that really the idea is that, the full spectrum of any mental health or behavioral health needs are being met. And that's really the role of, I think CalAIM, there's already the benefits available, really linking folks to those services. And to the extent that they qualify for enhanced care management, that would be the responsibility of those individuals who are the enhanced care managers to connect them up to whatever services are appropriate for them. So if mild to moderate, or like what we are calling non-specialty mental health services, which can be provided by the Medi-Cal managed care plans are appropriate, then those services should be coordinated for them. So lots of exciting things happening with Callium, but glad you're tracking that. And those are super complicated things to track, but glad everybody's keeping an eye on it. And it looks like Jane posted a lot of great information in the chat. So thank you, Jane, for getting all that info so quickly to us.
I should have had it already ready.
That was like rapid fire there. That was great. That was great. So I know we're a few minutes past, and really want to thank all of our attendees today, and our and a real special thank you to our panelists, Anthony Garcia, Jane Bond. Thank you so much for taking the time, really sharing your knowledge and expertise with us and our panelists. And I know they were in the background, but Juliana and Caitlin were also in the background helping out with facilitation. So a little shout out to you two as well. And then of course to our my CCJBH team here for doing such a wonderful job of coordinating all these activities for us. So really lifting up May is Mental Health Awareness Month with these wonderful activities, and just really networking this information with one another. So so thank you so much, everybody, and hopefully we can see you next week on our last lunch and learn for the month. So take care, everybody.
Everyone have
Thank you,
a great day.
CCJBH. Thank you, Brenda.
Thank you. Bye,
Thank you for
guys.
believing in us.
Oh,
Appreciate
yeah,
you very, very much.
For sure. Likewise. Thank
We
you
need
for
more
doing
people
this
like
great work.
CCJBH. Thank you.
All right, everybody. Take
Bye.
care. Bye-bye
Bye.
now.